Thank you, and thanks for the invitation to give this presentation. So my name is Carsten hjorthøj. I'm a senior researcher working out of Denmark in the Copenhagen University Hospital. And we have done this systematic review and meta-analysis on the years of potential life lost and life expectancy in schizophrenia, which was published earlier this year in Lancet. There have actually been several systematic reviews conducted on the area already, and when we looked into it, actually some of these systematic reviews had included upwards of 100 and more studies. So why do more than this? Well, I'll get a little bit back to that. But one of the things that we noticed was that most of these studies had some different focus than what we would want. So they had usually focused on the standardized mortality ratio, which is a measure comparing mortality in one population to that of a background population. So if you have a standardized mortality ratio of 1, sometimes stylized as 100, that means that the age and sex specific mortality rates are the same as the background population. Or if you have a one that is above 1, then of course it means that you have a higher mortality rate than would be expected in the background population. So a lot of studies have focused on that, and we know it's increased. I'll have some examples in a little bit. Other meta-analyses and systematic reasons. So like I said, a lot is known already. For instance, we know from these previous systematic reviews and meta-analyses that the standardized mortality ratio is probably around 2.5. So at any given time, it is much more likely that a person with schizophrenia would die than a person in the background population. So this is quite a large number. We also know from these reviews that there appears to be an increase in this mortality ratio over time, which is sometimes referred to as an increasing mortality gap. It probably is not so much because people with schizophrenia die more now than they did previously, or die earlier now than they did previously. It's probably more a case that people in the background population have had an increase in life expectancy, which has not been mirrored to the same extent in populations with schizophrenia. So this is fairly well established. Other things that are fairly well established from previous studies is that there are a variety of predictors of this increased mortality. These include substance use disorders. I'll have a few slides on that in a second, just because it's something that we did ourselves. So I figured I'd do a little bit of advertising of some of our older studies there. Tobacco smoking is a large predictor of increased mortality, and this is not surprising. We know that use of substances and use of tobacco is much increased in patients with schizophrenia compared to the background population. So it is not surprising then that this also predicts this increased mortality. Obesity, diabetes, and so on are also important predictors here. And furthermore, if we look more at cause-specific mortality, we know that suicide is very much increased in schizophrenia. Some studies show upwards of 100 times increase in suicide rates, especially if you look at the period just following discharge from psychiatric hospitals. Again, not very surprising, perhaps. Another thing is that cardiovascular mortality is very much increased in schizophrenia. It actually seems to be the most important single contributor to this increased mortality. Again, this is not surprising. So, for instance, we know that if smoking and obesity are more common in patients with schizophrenia, this would be expected to also be reflected in cardiovascular mortality. There are also some quite interesting apparent genetic overlaps between various cardiovascular diseases and schizophrenia, so again, maybe not so surprising. And finally, we know that there are other things such as sedentary lifestyles, poor dietary habits, and so on. So we're not really surprised by that. So I'll get back to our the study I'm supposed to be presenting in a second, but I just wanted to go a little bit further into this background about substance use disorder and mortality in patients with various mental disorders. We did a study a couple of years ago in which we looked at how much of the increased mortality might be attributable or at least occurring in people with substance use disorders. And so this slide is including both patients with schizophrenia, bipolar disorder, or unipolar depression. And then we have the red bars here reflecting those who have a lifetime diagnosis of substance use disorder, and the blue bars would then indicate those patients who never had a lifetime diagnosis of substance use disorder. And again, then we have the standardized mortality ratio, which if they had the same mortality rate as the background population, we would be down here at 1 on this black horizontal line, and you can see that it's much increased. So for instance, schizophrenia, both men and women with substance use disorders have around 8 to 9-fold as the mortality rates of the background population. But it's not the case that all of this increased mortality is explained by substance use disorders. So if we look at the blue bars, those are the ones that do not have any, at least diagnosed in the Danish registers, substance use disorders. And mortality is still very much increased, still by a factor 3 to 4. So these are very high numbers, and are also somewhat higher than we have seen in some of these meta-analyses. I don't have any really good explanations for that. But if you compare then the red and the blue bars, you get sort of a picture of how much of the excess mortality occurs in people with substance use disorder. And I would say that it is around the size of 1/3 to 1/2. This does not necessarily mean that it's causal. It doesn't necessarily mean that they die because they have substance use disorders. It could also be an indicator of more severe illness and so on. We took this a bit further and looked further into different types of substances. So for this analysis, then we threw away the background population. So now a value of 1 here, this time a hazard ratio. A value of 1 is now no longer in comparison to the background population. It is a comparison to people with, say, schizophrenia, but without any substance use disorders. So that's now the new reference group. And for schizophrenia, we see that all substances do increase in a statistically significant manner mortality compared to those who do not have substance use disorders. This goes for both alcohol, actually goes for cannabis as well, and goes for hard drugs, which was basically just a pooled category of everything which wasn't alcohol or cannabis, but was diagnosed in the registers. And then as expected, combinations would then increase mortality even further. And we saw much the same picture for people with bipolar disorder and unipolar depression, except that here cannabis was not a significant predictor of increased mortality, which may indicate that people with schizophrenia use cannabis differently or for different reasons or in different quantities compared to people with bipolar disorder or unipolar depression. Or it could also be some case of interaction with tobacco, which we were not able to control for, given that these were Danish register-based data. So that's all I'm going to say about the background from a previous study. But like I said, most previous systematic reviews have had these focuses of using either predictors of increased mortality within these populations, so hazard ratios or standardized mortality ratios comparing to the background population. But there are other and more direct measures of mortality, whereas the ones constructs. So if you take the life those 2 euros and so on in 2016, then a population of such individuals would on average be expected to live this long. This is of course not true. We know that they will not have this the same age and sex specific mortality rates. So it's not really a measure of how long a person born in 2016 can actually expect to live. It's more a measure of the health status of the population as it is in 2016, which makes it very interesting for the type of purpose that we're looking at here. And then you can also use that to calculate something like years of potential life lost. So if you have life expectancy for people in the background population and life expectancy for people with schizophrenia, then obviously the difference between those two will be the years of potential life lost. Now, there are a few problems with doing that, because if you estimate life expectancy at birth for people with schizophrenia, then you actually do know that they're not going to die until they get the diagnosis of schizophrenia. So typically, most studies would then estimate life expectancy at a later age, so age 15 or age 25 or whenever, which was also the case in some, but not all of the studies that we included, but I'll get back to that. But our aim then was to perform two sets of meta-analyses, one on the life expectancy in schizophrenia and one on the years of potential life lost in or due to schizophrenia. And we had a further aim or hope to be able to identify subgroups. So for instance, was there an indication that there were period effects, so that it was increasing or decreasing over time? Or perhaps if there were geographical differences related to regions of the world, perhaps where in which years of potential life lost, life expectancy differed from other areas of the world. We also looked at risk of bias and sex, obviously, and further other stuff. Did it in the manner that we had said that we were going to do, so it is pre-specified. We searched various bibliographical databases. We thought that the fives that we listed here would be the ones that would be most likely to capture all of the literature that we were going to search or desire. And actually, Medline would probably have all of it, I think. But there are a lot of problems with only searching one database. Many people don't realize that the overlap between these databases is far from perfect. We did, two researchers did this literature search. That is to say, I did just set up the original literature search, but then myself and Sturup, a PhD student here at our department, then went through all of the lists. So just to give you an example of a search strategy, those of you who are familiar with systematic reviews will find this pretty trivial, but just in case some of you are not familiar with this, I'll just quickly go through this. This is a strategy from PubMed, which is an entry point to Medline. We divided our search into two blocks, one relating to participants over here and one relating to outcome over here. We used mesh terms, which is sort of a way of categorizing studies according to predefined terms, so not necessarily the ones that the authors themselves use. So what we did simply is, within each block here, you then combine with the Boolean operator OR, which means that you get a very large group of results. Same thing over here. And eventually you combine the two with AND, so you get fewer results. And sometimes fewer does not mean few. I'll show you how many we got in a minute or two. Our inclusion criteria were quite simple. The studies had to report life expectancy or years of potential life lost. We had to have people who were diagnosed with schizophrenia according to either the ICD system, the DSM system, or the research diagnostic criteria. Actually, all studies were eventually using ICD in our meta-analysis, so we are not able to determine whether there are any differences according to diagnostic system. We didn't have any exclusion criteria. In cases where studies did not report all of the information that we were interested in. For instance, some studies did not report the full number of people with schizophrenia. We contacted the authors to obtain this information, and in most cases, the authors were able to provide this information. So we extracted the number of people with schizophrenia, the country or region. Eventually, we grouped this into the continent that the study was from, study period, source of data. So was this hospital data register based, or how was the data obtained? Of course, overall life expectancy and years of potential life lost, as well as these measures in subgroups if these were available. Usually this was only the case for sex, so life expectancy or years of potential life lost for men and women separately. Finally, we performed a risk of bias assessment using the Newcastle-Ottawa scale. I've just taken it with me here just to show you what this is. So it's a way of assessing how large the risk of bias in a study is. It's sort of comparable to the Cochrane Institute's risk of bias assessment tool for trials, but it uses different categories, of course. So how representative are the cases with schizophrenia? Are they hospitalized cases, which means that it might be a case of more severely ill people and so on. How was it determined whether or not these people had schizophrenia? They obviously were not dead at the time of the study, so that's not really interesting for us. Quite importantly, it should be age and sex specific life expectancy or mortality rates that were the output of the study. So if any studies did not provide that, it would be a potential bias in the study. And how was death determined? Was there any loss to follow up? And were the studies actually having a long enough time period to actually allow people to die? As for the meta-analytical part, there's a quite standard way of doing this. It revolves around inverse variance, which was not really possible to do in our case here, mainly because not all of the studies provided measures of uncertainty. So some studies would report years of potential life lost, for instance, but with no standard errors, no confidence intervals, or nothing. This means that we would not be able to calculate what the inverse variance was. So instead of using that to determine how much weight each study should have in the meta-analysis, we instead made the simple decision to use weighted averages. So the number of people with schizophrenia was then the study weight. So the larger the study, the more weight would it have in our meta-analysis. We did compute confidence intervals around these weighted averages. Again, this is a little bit difficult when you don't have standard errors or confidence intervals in all of the included studies. So what we did instead was we used an inverse variance fixed effects meta-analysis on the studies that did report measures of uncertainty, and using the standard error that was then the output of such a meta-analysis, we then extrapolated that standard error around the weighted averages. So this probably has the effect that our confidence intervals are a bit wider than they have to be. So it's sort of a conservative choice, but it's the only choice that we could really have made. Now, to take you a bit through the results, so like I said, we researched these databases. You sometimes get quite a lot of results, even though you start by a lot more. But we've identified originally 13,500 studies. We eventually also looked at the reference list of the included studies, but we didn't find any other studies, which is a good thing. It probably means that our literature search was okay. Not necessarily, but probably. There were some duplicates, so just short of 12,000 after these were removed, and simply going through the titles of these almost 12,000 papers, it was possible to exclude nearly all but some 800 studies. So more than 11,000 studies could actually be excluded on the title alone. Then there were 762 studies remaining where we went into the full text to see whether they actually fulfilled the inclusion criteria or not. Most of them did not, and the reasons are given out here. but then eventually 13 papers remained. However, in 2 cases, there was both a paper and a conference abstract for a study. So these 13 papers reflect 11 studies. This is important so that the same study would not show up twice in the meta-analysis. And now for the actual results. So what did we find? So starting a little bit backwards, perhaps, by looking at the years of potential life lost, which, well, we started with this because we actually thought it was the most interesting bit. The bottom line here will show all of the studies pooled. So 14.5 years of potential life lost in people with schizophrenia compared to the background population. So nearly 15 years. And just to be clear, so like I said, there were 11 studies included. Some of these were from the same countries or had potentially overlapping populations. For instance, there were 2 studies from Denmark. And in cases where this was happening, we chose the lowest number of potentially life years lost so that we would get the conservative estimates. So actually the actual number can be higher than this. So a little bit higher for men than for women, some 16 years for men, or 15.9, 13.6 years for women. There were some regional differences as well. The thing is, there was only 1 study from each of Africa, Asia, and Australia, so it's a little bit difficult to conclude much about these. And the 1 study that we identified from Africa was very, very small, so maybe it is a good idea to not put too much emphasis on this study. This is the Fekadu study here. Like I said, it's very small, so it doesn't really skew the meta-analysis much. But apart from that, you can see over here that there are maybe some indications of regional differences, with Asia actually being a little bit losing fewer years to schizophrenia than the other countries. But again, the confidence intervals are wide enough to not really be able to conclude much about this. As for life expectancy, you see sort of the same picture. Now you just have to sort of imagine that you're mirroring it on the y-axis, because of course now it is good to have many years of life expectancy. We did one thing which sort of maybe explains why I talked a lot about this, whether or not you should measure life expectancy at birth or not. So some studies would measure life expectancy, say, at age 15. So we would then simply add 15 to the number of to life expectancy at age 15 to generate what we would call an expected age of death. And again, with the caveat that this is not really what the life expectancy shows. And the overall estimate here was 64.7. Again, as expected, higher in women than in men. But if you recall, then there were also more years of potential life lost in men than in women. So yes, we do know that women in pretty much all populations tend to live longer than men, but it's more skewed in people with schizophrenia than it is in the background population. And again, there are some regional differences. So Africa in the bottom here, but again, don't put too much into this. It's a single, very small study, and it has some other things that set it apart a little bit as well. Asia, sort of, then the next step, and then the remaining regions a little bit higher. In case some of you have downloaded the paper or are going to download the paper, there were a few errors in this figure here in the published paper. They are being corrected and will be corrected online, I think, by the end of this month. Nothing that really changes anything, but there were a few errors of minor importance. So what to make of all of this? Well, these are basically just numbers, and we don't know much about what else is going on. But to summarize a little bit, so around 13 to 15 years of potential life loss to schizophrenia. So schizophrenia does cause people to die earlier than they would have, or cause, but it is reflected in mortality. There were, I didn't show that, but there was a few indications that it was a little bit higher in studies that had higher risk of bias, but I don't think that's particularly important. It's also a little bit higher in men, which is interesting. and something to consider when you think about what the reasons for it might be. And if we take the African study out, then there were the fewest years of potential life were lost in Asia, then North America and Australia in the middle, and most in Europe. Like I said, we don't have any indications in our study of the reasons, so this was not our aim, and we didn't look into this, but we do know from other studies what contributes to this. I've already mentioned a bit about this. So cardiovascular disease, diabetes, side effects of medication that we know have cardiovascular and obesity, weight increasing side effects, lifestyle factors, so smoking, alcohol use, sedentary lifestyle, lack of exercise, poor dietary habits, so on. Poor health-seeking behavior, and I just want to disagree with myself on the term here, because yes, it's probably or definitely true that people with schizophrenia seek out medical or physical medical health less than the background population does. But it's also well established that once they do actually seek help, then they do not get the same level of treatment as people in the background population. So there also appears to be a tendency for the health system to sort of downplay the importance of the complaints, physical complaints that patients with, for instance, schizophrenia present with. So you have a patient who you know to be psychotic and paranoid and so on, and this person is presenting with chest pains. Maybe you have a higher tendency to attribute this chest pain to probably psychiatric causes, but this is definitely not necessarily the case. And in fact, we do know that they have a higher rate of cardiovascular illness. So it's actually, maybe you should listen more to these patients than you should to the background population. Like I said, suicide and genetic factors probably also play a large role in these numbers here. And also, to summarize, life expectancy converted to the expected age of death, so 64.7 years overall, 59.9 for men and 67.6 for women. The geographical ranking of this was very much similar to the background population. I have a little bit of discussion about the geographical variation in a few slides. And this wasn't really influenced by risk of bias. So I don't think risk of bias is really that important in our study here. Again, probably because there are no important conflicts of interest that I could think of here, which is also the case why I don't think a publication bias is going to be relevant here. I do believe that if people have investigated years of potential life lost or life expectancy, then they are going to actually publish it. And this geographical origin bias, as I would call it, is that, well, we included 11 studies, and for instance, for Asia, Africa, and Australia, there were only single studies. So how much emphasis can we really put into this? And for instance, the Asian study, it was from Taiwan, which has a population of, well, I looked it up in Wikipedia, it's at 23.5 million. And I don't know if you know this, but the entire Asian population is around 4.4 billion. So this would only reflect around 0.5% of the entire Asian population. It's probably more valid for Europe and North America because we had more than one study from these regions. However, again, most of the European studies were Scandinavian or from the United Kingdom. So again, Southern Europe, Eastern Europe, Central Europe, very much underrepresented. So how much these numbers then would be generalizable to other areas, it's a little bit difficult to know here. So there might be a geographical origin bias, and it would be nice to have more studies from other areas. We do believe that we have some very important strengths in this. So we did a systematic literature search. We did contact authors when there were no data that we could, or when there was missing data in the studies. And like I say, I don't think there are any missing studies. I do believe that we've caught all that was out there. That said, there's also the limitation that we included only 11 studies, and you can contrast this to the 100 or more studies that have been published with measures such as standardized mortality ratios or similar. So this means that a lot of studies out there have looked at mortality in populations with schizophrenia, but without reporting life expectancy or years of potential life lost. So it would be very interesting to know if what would happen to our meta-analytical results if we had been able to get data from all of these 100 and more studies into our study. Further limitation is the lack of standard errors and confidence intervals in many studies, which means that we sort of had to invent our own meta-analytical approach. I think we did the best thing possible, but it's sort of new territory, not that it's specifically or particularly complicated what we did. And a final limitation, if you would call it, so I'm not sure I would call it a limitation, I would actually probably just call it more something to remember and be aware of, is that life expectancy and years of potential life lost, these measures will be mostly influenced when the mortality occurs in younger age groups. So if a person dies at age 20, it has a large impact on life expectancy. Whereas if a person dies in years age 55, it'll have less of an impact on life expectancy and years of potential life lost. So you don't get the full picture. You get some of the picture here, but especially once you start to then decide what should we do about it, then it would be easy to only focus on the younger age groups so as to change or increase life expectancy and decrease years of potential life lost. But there are other things to also remember here that are important because mortality is still increased also in the higher age groups of people with schizophrenia. So in summary, some take-home messages. Around 13 to 15 years of potential life are lost to schizophrenia. It's more so in men than in women. I didn't really show this, but there weren't any indications of improvement over time. It's a little difficult in these 11 studies because there weren't that many time variations in the studies to really make sure about this, but it didn't really appear to be the case. But it certainly is obvious that there is a need for interventions. So there's both a need to develop interventions. So how can we, what is actually an effective way of helping these people to have a lower mortality rate? And probably also there is a lot of knowledge out there already on what can be done. So better management of somatic or physical health complaints, and more careful monitoring of medication side effects, and lifestyle interventions and so on. But maybe it's also the case that they're not adequately implemented. And but this is a bit beyond the scope of our systematic review here to go into, and so I'll leave it at that. And this will actually be the end of my presentation. So finally, I would just like to thank those of you who are here online, and those of you who eventually will see this on the YouTube channel, and